the field of CAR T cell is evolving rapidly, and we're identifying more and more factor associated with response. I mean, I would say that as of today, there are still not really biomarkers of response that are used to select patients or that have some predictive value that is sufficient to for us to change our approach. However, we know that patients that have a high tumor burden, as seen at imaging or LDH, they have a poor outcome. And so we try to avoid to treat those patients. We know that patients whose T cells are not highly functional, and this is determined, I mean, mostly we correlate that with the previous use of chemotherapeutic agents, line of treatment, can also have a not optimal outcome. And I would say that we also look at the tumor, and we look at, for example, antigen expression. There are some data that show that if you have negative clones, they're most likely to develop antigen-negative escape. In the tumor microenvironment, obviously, there are also factors that are associated with poor outcome. For example, the macrophages or Tregs recently have been identified. But again, I would say that despite the presence of a lot of studies that look at different, let's call it mechanism of relapse, truly use biomarkers in the clinic are not present. I think it's still the LDH is still the most reliable one, and tumor burden is the one that really dictates if we want to give the therapy to a patient. But as of today, we don't really use these markers to assign a new therapy. But again, just to summarize, composition of the tumor microenvironment, the quality of the T cell, and you can look at the product or the apheresis, where if the cells are less differentiated and less exhausted, they do better. And a characteristic of the tumor cell themselves, like expression of antigen or expression of PD-L1, for example, can be correlated with outcomes. But again, are we to the point where we can use these biomarkers to select the best therapy for the patient? Not yet.